I'm greatly honored to be able to speak among the giants in the field. So just now I heard before the laser presentation that there's minimal, not too much evidence. So this is something new. So there's minimal evidence, but I'm going to go through with you what's going on with this microwave ablation. So we call it targeted microwave ablation, TMA. And the other important thing is we actually started off using a navigation-guided treatment with a coilus, with the organ-based tracking. Sorry. So we fully believe, after doing years of MRI ultrasound fusion biopsy, when we do it an MRI ultrasound fusion guided for treatment, we should do it in the same way instead of the cognitive guided. So in fact, besides microwave, I do high field and cryo, and all of them were done on the MRI ultrasound fusion from in the early days that we started like 4 years ago. So the first few slides will be on organ-based tracking of this MRI ultrasound fusion system. Probably many of you have experience on that. Basically, the ultrasound probe will follow the moving prostate. Despite the patient being under general anesthesia, in fact, when you put in a needle after a biopsy needle, it actually moves. So actually follows. There's still an error of 2 to 3 millimeters, but I think it's very accurate and it actually follows. Just for example, this case of 7 millimeter parts for left anterior T-zone lesion, not very apparent on a T2, but quite obvious on a DWI and ADC. Did a targeted biopsy. For the trial, for this case, it's not actually what I usually do. It's a targeted biopsy, 3 to 4 course plus 18 course of systematic biopsies as a minimum for appropriate case selection for my focal therapy. For this case, it's like all 4 targeted course with Gleason 3+4, and all the systematic course with benign. And this is another example to illustrate how do we select the cases that comes into this trial. I actually do rather a comprehensive mapping of it. So this case, you see, what I do with the lower half of the prostate? Did I not take it? No, because my colleague actually took another 20 course like 6 months before this case, and it turned out to be negative. And then we did an MRI at the time, and the yellow, the 5 yellow circles there were actually not MRI lesions, were actually the thing that I marked deliberately, so I can actually tell myself where's the lesion, and it turned out that 2 of them, actually 3 of them actually have some 3+3 lesion around that, so actually during the treatment I actually covered them. So the first message is we believe that accurate targeting is actually the basis when we plan for this microwave treatment. So this is actually the machine that we use. In fact, this is almost, when you look at it, it's basically almost the same as the MRI ultrasound fusion machine of the Coalesce Trinity system. So the tiny microwave generator next that is hanging onto the machine, slightly smaller than your backpack, is actually the energy. And we use 1 microwave needle per case. So it's a 17 gauge needle, for any microwave needle, the ablation zone would be controlled by the power and the time. For this system, in the initial stage, we actually set the power at 12 watts at a uniform power, and therefore we control the ablation zone by increasing the time from 2 minutes to 5 minutes. So up to 5 minutes, the ablation zone would be with a length of 3 centimeters and the diameter of around 17 millimeters. Although it varies from patient to patient, we can do it in a bracket grid. We can do it with a mini grid. So after the first 10 cases, I actually have abandoned the full grid because the mini grid is much more flexible, and I could actually go to the areas which would traditionally be more challenging with a bracket grid. So this is a short. Can I illustrate that? Yeah, this is a short video showing. So this is 1 microwave needle, and there's a cable connecting the small microwave generator with this needle. So this is kind of slightly off-center lesion. So the tip is actually not at the center of the ablation. So as you can see, this is very similar to what we do biopsy. In fact, we're using the same software for fusion biopsy, and we're using the same software for fusion guided ablation. So in fact, it's the same software that we can actually use for fusion-guided IRE or fusion-guided cryotherapy. I don't do IRE, I have no experience in that, but when I do Galileo cryotherapy, I use exact same software for that. But the only thing different is I choose cryo needle instead of microwave needle for this. So basically, we set up everything, this transperineal application. We've targeted that on ultrasound fusion, MR ultrasound fusion, put in a needle, connect to the cable, and press start. And it's usually within, so again, this is organ-based tracking, so it's like scan after I put in a needle to confirm exactly where my needle went. And this is during the treatment. You can see there are some like popcorn changes, like as you can see, like during the HIFU. We don't have that clear-cut cryo, front that we see during the treatment, but we still see very obvious ultrasound changes in most of the patients. So I'm gonna build up time. The first safety trial was done in France because Coelis is a French company. So it's done in Paris by Dr. Delongchamps. So in 10 patients, and at that time there was a transrectal puncture with a microwave needle. Subsequently, we all changed to transperineal. So it was shown to be safe, but because in that trial, it's only one ablation per patient, so most of them, so the tumor control is not good because there's no margin, but that is only to show the safety. These are the photos taken in my OR in a transperineal ablation using this TMA system. So below here is the full grid that I use, and then subsequently I change all to mini grid. I'll explain why, because sometimes when the lesion is maybe anterior or actually or slightly obstructed by the bone, I can actually use the probe to move it around, and even for the midline anterior lesion, I can actually insert at an angle from left or to right to add the margin on the left side or the right side. It's actually quite easy. So you can see the trajectory of these 5 needles are actually going in through different angles. And as said, this is from the beginning, and then at around like 2 minutes, and then the end would be around like 5 minutes. So these ultrasound changes. I've learned along the way that the ultrasound changes actually corresponded to the MRI ablation zone at 1 week. So when I see the treatment changes not as good as I expect, I actually can prolong the treatment time by another 2 minutes or 3 minutes, which then I like to achieve the similar ablation zone that I see on the ultrasound. So I could easily treat the other side now. This is arguable because the other side, this is a 3+4 lesion on the right anterior, left lateral on the systematic cord, not an MR lesion. That's actually just a 3+3 3mm thing, which we could actually decide not to treat it and do it as active surveillance, of course. But this patient actually strongly suggests me to do that. So I'll say, okay, I'll add another 4 minutes treatment center for that side. So the treatment time, it's usually between 20 to 25 minutes. The ablation time. The treatment time is usually around like 60, 65 minutes OR time. So sometimes, because this is a thermal treatment, so when I go slightly closer to the rectum, this is not that close, but I still put in some normal saline below the prostate, between the rectum and the prostate. So it's actually quite easy because I'm using a mini grid, so it is always in line with the ultrasound. So it's very easy to put in a spinal needle just below my microwave needle, so it actually goes straight into without me finding my own needle, because it's actually in the same plane. So this is just another short video about like how I plan for that. This is basically the same way. I draw the urethra because I want to know before ablation how much would the ablation cover the urethra on one side. I also draw the rectum, but the rectum side is probably to make it nicer to let me see what's going on. So this is, and after inserting the needle, as said, we'll scan it over again around like 4 or 5 seconds, and we'll put in exactly the location where our needle was, and then we start the ablation. Okay, so this is kind of a similar. Okay, so Right, so this is one case, somehow not day 7, but day 10, with a T1 with a gadolinium contrast. I put in 5 needles for this case, around like 25-minute ablation in total. So it's a sequential ablation, showing good coverage. Sometimes these patients, because of bilateral anterior periurethral, like we may need to like take the Foley's catheter for like 7 or even up to 10 days. Yeah. But they do well afterwards. So this is the first publication on just the first 15 cases in this pilot study of 30 cases. In-field 6-month mandatory biopsy shows 91% no cancer. It's not no high-grade cancer, it's no cancer. And the median PSA was from 7.7 to 2.4 at 6 months. So this is really a quadrant treatment. Sorry. So this is the final analysis for the 30 patient, which is under submission. So it's showing a very consistent result of around 90% with no cancer on the targeted biopsy. So it's the in-field no cancer, 90%. However, out of field, there are actually 3 patients with out of field, which because at the time in our protocol we have no retreatment plan, so we actually subjected patient to radiotherapy and prostatectomy. And only grade 1 complications were seen. This is the other European trial, Violet trial, that is going on, and I heard it's just finished a recruitment of 65 cases with a multi-center from France, Belgium, and Germany, and the primary outcome would be the proportion of patients with the in-field positive biopsy at 1 year. So we still have to wait for another year for the results. So in conclusion, despite having not much evidence up to date, but transperineal microwave ablation as a focal therapy for localized prostate cancer is shown to be safe, and I think it can be very precisely performed under organ-based tracking, MRI, ultrasound fusion, and further trials are actually getting on. So thank you very much.